All right, let's dive right into a critical topic in obstetrics, hypertensive disorders of pregnancy. This is absolutely core, high-yield material that you're gonna need for clinical practice.
So why the focus? Well, check out this number. Roughly 1 in 10 pregnancies is complicated by hypertension. This makes it a huge contributor to both maternal and perinatal morbidity and mortality all over the world. So yeah, understanding this is essential.
Okay, first things first, let's get our fundamental definition down. We officially call it hypertension in pregnancy when the systolic blood pressure hits 140 or higher and/or the diastolic is 90 or higher on at least 2 separate occasions. This is the magic number, the threshold that kicks off our entire diagnostic and management pathway.
So here's our game plan for this explainer. We're going to follow a really logical clinical workflow. We'll start with classification and pathophysiology, then move through diagnosis and urgent management, and we'll wrap up with timing of delivery and postpartum care.
The very first step in management is always accurate classification. This is so crucial because it dictates your entire approach. And you know what? It all comes down to one simple but critical question. When did the hypertension actually start?
So here's the basic framework, and it's all about timing. If that high blood pressure is there before 20 weeks of gestation, we're dealing with chronic hypertension. But if it's a new thing, something that pops up at or after 20 weeks, our diagnosis shifts completely to the pregnancy-specific disorders, either gestational hypertension or pre-eclampsia.
Now, for your patients who already have chronic hypertension, there are some key principles you've got to follow. We're constantly on the lookout for superimposed preeclampsia and fetal growth restriction. The big actions? First, stop any teratogenic meds, the ones harmful to the fetus, like ACE inhibitors and ARBs. Then, we start low-dose aspirin from 12 weeks to lower that preeclampsia risk, and we aim for a target blood pressure of 135/85 using pregnancy-safe drugs like labetalol or nifedipine.
To really manage preeclampsia well, you have to understand that at its heart, it's a disease of the placenta. The maternal symptoms we see, that's just the end result of this underlying placental problem.
The pathophysiology is a classic 2-stage process. So in stage 1, you get this abnormal placentation. The trophoblast cells just don't properly remodel the uterine spiral arteries. This creates a high-resistance, poorly perfused, and ischemic or oxygen-starved placenta. Then comes stage 2. This unhappy placenta starts releasing these anti-angiogenic factors into the mom's circulation, and that causes widespread endothelial damage and the multi-organ syndrome that we recognize as preeclampsia.
So how does this maternal syndrome actually present in the clinic? Well, the diagnosis really hinges on finding that new onset hypertension after 20 weeks, plus some objective evidence of either end organ damage or significant uteroplacental dysfunction.
Now here's a key diagnostic pearl. Proteinuria, while super common, is no longer mandatory to make the call. If you have new onset hypertension after 20 weeks, any one of these other new conditions like kidney or liver dysfunction, low platelets, neurosymptoms, or fetal growth restriction is enough to diagnose preeclampsia.
Okay, these are the red flag symptoms you absolutely have to ask every single patient about. A severe headache, visual changes like flashing lights, or that classic epigastric pain, these are not benign symptoms. They are alarm bells signaling significant neurologic or liver involvement and a rapidly worsening disease process.
This brings us to the most critical phase, managing severe disease to prevent a maternal catastrophe. When preeclampsia gets severe, it is a true obstetric emergency, and your actions have to be fast and precise.
So, our emergency threshold is a systolic of 160 or higher or a diastolic of 110 or higher. When you see these numbers, the immediate goal, the #1 priority, is to prevent an intracerebral hemorrhage. That's a leading cause of maternal death in preeclampsia, so we have to act fast.
So, what are your go-to drugs for acute control? You've got 3 main players. IV labetalol is a common choice, but remember, it's a no-go in patients with asthma. Oral nifedipine is really effective and super simple to give. And then there's IV hydralazine, which is another good option, though you gotta watch out for a risk of reflex tachycardia and maternal hypotension.
Okay, so you're starting to get the blood pressure stabilized. What's the next urgent priority? Well, it's preventing the single most feared neurological complication of preeclampsia, an eclamptic seizure. And the answer, hands down, is magnesium sulfate.
This is the undisputed drug of choice for both preventing seizures in severe preeclampsia and for treating active eclampsia. The standard regimen is a 4-gram IV loading dose, followed by a maintenance infusion of 1 gram per hour.
But, and this is a big but, monitoring for magnesium toxicity is just as important as giving the drug in the first place. You have to watch these 4 critical parameters: respiratory rate, patellar reflexes, urine output, and O2 sats. Remember, losing the patellar reflexes is your earliest sign of toxicity, which can then progress to respiratory depression.
And if you do see signs of toxicity, you need to have the antidote ready to go immediately. And that antidote is calcium gluconidate, 1 gram, given slowly, intravenously over 10 minutes.
Now, while we're managing the maternal syndrome with blood pressure meds and magnesium, we can never forget the root of the problem. The only definitive cure for preeclampsia is delivery of the placenta. If any of these severe features are present, you have to deliver immediately, and it doesn't matter what the gestational age is. We're talking about things like uncontrolled hypertension, eclampsia, or evidence of HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. In these cases, the risk to the mother is just too great and outweighs the fetal risk of prematurity.
Finally, it's so important to understand this. The danger is not over after the baby is born. In fact, almost half of all cases of eclampsia happen in the postpartum period. This means you have to stay on high alert.
Postpartum care means careful blood pressure monitoring, especially during that peak risk period of days 3 to 6. Your medication choices are also critical. You want to avoid methyldopa because of the risk of depression, while breastfeeding-safe drugs like enalapril or labetalol are great choices. And crucially, you must avoid ergometrin for managing postpartum hemorrhage, as it can trigger a hypertensive crisis.
So if you remember just one thing from this entire explainer, let it be this high-yield clinical pearl. Your vigilance has to continue well into the postpartum period. The blood pressure often peaks between days 3 and 6 after birth because of major fluid shifts. The danger does not end at delivery.